All right. Good morning, everyone. I'm going to go ahead and get us started. So I'm Don Nease. I'm a family doc here at the University of Colorado, Department of Family Medicine, and I oversee our SNOCAP practice-based research networks and also have the pleasure of working with our CCTSI, which is our Colorado Clinical and Translational Sciences Institute, and their partnership of academicians and communities for translation. So that's our community engagement crew here on campus. Joining us remotely, I've got Mike Klinkman from University of Michigan, who's waving up there in the upper left-hand corner. And we have guests today from the UK, Mike Martin and Nick Booth. And they'll say a little bit more about themselves once we kind of get going here and get into their sections of the presentation. I really also want to acknowledge and thank Lauren Ambrosiak and the Colorado Prevention Alliance. This is part of a sort of a stream of conversations that Lauren gets all the credit for initiating and kicking off. She's giving me a funny look. She's been incredible in terms of helping to convene these conversations. Lauren, do you want to say anything?
Sure. So I don't know if that should be credit or blame. I just wanted to say that Don and many of you in the room have been part of these conversations around social determinants of health and how do we do a better job of connecting and bridging those gaps and getting people to the community and social resources that they need, whether they're in a community setting or in a medical setting, and kind of how do we think about that collaboratively across the state. And so Don has been part of these conversations for quite a while and has a really interesting also other perspective that he'll share with us today. So we just wanted to be part of creating the space to have all of these various conversations and then meet them together. So that's, I think, all I have to say.
All right. Thanks, Lauren. And I know we have folks that are joining us remotely as well. So just to make sure that you all have your mics muted, and once we get to areas, we'll have some natural pauses here where folks can break in, ask questions, and if there's something burning, please don't hesitate to raise your hand, and we'll try and address that as we're going on. I think we've got plenty of time today, and really the goal is to have a conversation about this information and these concepts. Okay. Let's see if the doctor can work the remote. All right. So first, we're just going to kind of give a broad orientation to the perspective that we're putting out on the table today. Then we'll talk a little bit about some terms, architecture and infrastructure, and how that informs our thoughts about how the bridging care information between communities and healthcare can be done. And Mike Martin from Newcastle is going to lead that section. Nick Booth is going to talk a little bit about experiences that he's had in the UK, really being at the table and a leader in the UK's efforts in health informatics. And Nick's work is grounded in the experience also of a family doctor, GP, working in the north of England. Then we'll have Mike Klinkman say a few words about work that he's been pursuing along similar lines in Jackson, Michigan, working with the community there, which is just west of Ann Arbor, a community of about 25,000 people. And then we'll have some time for discussion and next steps. Everybody feel like they're on the right flight? Okay, good.
Hey, Don, do you want to do a sound check? Just make sure.
Yeah. Are you hearing me? Are we good in the booth? All right, I see a nod and a thumbs up. Great. So we've traveled a bit over the past week. Does anybody recognize where this is? San Luis Valley. This was leaving Durango, where we were very honored to present to folks with the Western Colorado AHCM. They're about to rebrand themselves, I think. All right, Catherine?
Yeah, the Federation.
So that was a lot of fun. And prior to that, we had been in Colorado Springs at the North American Primary Care Research Group meeting. And we did a forum on this topic at that meeting on Wednesday morning. So we've managed to show Nick and Mike a bit of Colorado, which has been fun. So, throw out some ideas and concepts here. First one is, it's really our perspective that it's no longer okay for us just to keep information and records about a person's health or care siloed. We've got to get past that in order to really provide the best care to people. And I'm going to be very intentional about that use of the word care because we think it is a more inclusive term that spans community as well as the traditional healthcare organizations. Health and care record technology has really failed to interoperate to serve citizens or the people rather than single institutions. I mean, this is really about the public and public good. Clinicians and their patients have not rarely, if ever, been at the center of the design decisions that have been made about these tools and applications, electronic health records. We really haven't had a single vision or leadership to develop commonly owned infrastructure that would allow for the release of information, data, and care information from patients, organizations that could also be used for research. We want to focus on the nature of the clinical interaction. Okay, so what happens between clinicians, patients, community service folks, and clients, and this notion of shared infrastructure. We feel like there's a need for openness on data use with individuals in the population, but openness that is protected by some governance, some way for us to make sure, as you'll hear Mike say later, continually, is this what we intended to do? Are we headed down the right path? Is this what we mean to happen? And then finally, that weaves into this notion of a social contract to help make sure that people trust what we're doing with their information, that they can feel confident that we're handling that in a way that is not only safe, respects their interests, but also enables care. One of the things I find really interesting when I'm seeing patients is patients sort of assume that information is traveling around right now. And when I tell them, actually, no, there's all these barriers that have been set up, they're kind of surprised about that. So that's an important piece. Okay. So a few of you in the audience will recognize this. This is a concept, communities of solution, that goes way back to the late 1960s, to one of the foundational documents for family medicine in this country. And this comes from the Folsom Report. And the notion was that communities should have the ability to organize around the problem areas that are facing them. And that was 1967? Something like that. Yeah. Right now, we're just kind of at the cusp of if data could be harnessed by the community to really enable that sort of a community of solution approach. And I think it's a great vision for the work that we'd like to see happen. So I'm going to hand things over to my good friend and colleague Mike Klinkman, whom I worked with for many years at the University of Michigan before I got lured out here to Colorado. And Mike's going to take us through an example of a patient from the community that he works in Jackson, Michigan.
So hi, can you all hear me okay? Is the sound coming through?
Sounds great, Mike.
Great, okay. So sorry I can't be there. spent the last week in Colorado and I had to get back to my day job. So I'm sorry I can't be there talking to you face to face. The context here is we've been working in the community of Jackson on trying to organize and coordinate care for people who have sometimes complicated needs, but just sometimes people who have needs across those medical and social and behavioral boundaries. This is a real person, Millie Jones, although that's not her real name. And as you can see through this slide, she's a typical person living in the community that I'm serving. She's a 72-year-old. She lives with her husband, who's a little bit older, and she lives in an old farmhouse a few miles out of town. She's got a number of medical problems: type 2 diabetes. She's got peripheral vascular disease. She's got neuropathy. She's got congestive heart failure. Has coronary artery disease, and had a stent a few years ago. And like most folks that we see in this setting, she's overweight. She's got some mobility problems because she's got hip arthritis, got knee arthritis, and her husband had farmed the land until his own health made it really hard. So they're struggling. They're both noticeably now increasingly forgetful. They have problems managing their finances, but together they can kind of take care of themselves. Their income is Social Security payments. They get a yearly rental fee for land that they have leased to someone else to farm. Their money is managed by their son, who lives a few hours away, who sends a monthly allowance to his parents. They are quite reluctant to sell and move out of their home, partly because that's where they've lived for 40 or 50 years, and partly because it gives them some income as well. They don't drive, so they're sort of stuck. And their interactions with the medical care system have been a little difficult. They've declined services like Meals on Wheels. They're pretty stoic. They don't really seek medical care, and when appointments are made, they don't make them often because of transportation problems, so they do a lot of stuff. And to cap it off, Millie fell last week, but unable to walk more than a few steps without hip pain. This is Millie as we get to know her. Don, can I have the next slide? So he came to the attention of our care coordination group, and we sat around the table to try to figure out what we knew. Turns out that we didn't know a lot of stuff, and we also didn't know that there were other people involved. We knew when we sat down together to figure out how to better help her that she had a medical problem list, so we could see that. We could see the clinical information that was held in our electronic medical record. The team knew that she had some limited mobility. We knew that she declined Meals on Wheels and social services because that was prominently displayed in our chart. We could see her recent hospitalization event, but none of the data about that hospitalization event, because that was in a separate database at the hospital. And we see also that she had multiple missed appointments with her primary care doc and with a cardiologist. Now, we also learned that she had, for some reason, a Medicaid case manager. Now, why a 72-year-old person in our community had a Medicaid case manager is still pretty opaque to us. But that person checked in later when we looked for other people that were helping. That person knew that Millie had missed multiple medical appointments. That person believed that there was no real need for transportation of the baby because in their record, it said that the son will transport. Now, that son was living a ways away. And the case manager knew that she'd had 3 recent ER visits with congestive heart failure, and that's why the Medicaid case manager, for some reason, was getting back on the case, even though this was a 72-year-old person. The problem is, as we found out later, nobody knew about her degree of functional limitation. Nobody knew about her recent fall and what happened after that. Nobody knew about their increasing social isolation on the farm. Nobody knew about their increasing cognitive impairment. Nobody knew about their possibility that there was some abuse in how their son was handling finances. They were getting an allowance, but we didn't know what that was. We had no idea about the poor nutrition or the extent of their just struggling. So we figured that we had to do something. We started to learn about this stuff. And let me show you the next slide, Don. We really got involved, and Millie's by no means an exception. This is just the work that some of you that clinical care know happens. So over the next 3 months, the stuff that we did, you'll see on the left hand of this slide. The stuff and how it was done, you see the middle. And on the right, you see some things that we thought, even for our group, was pretty exceptional effort to try to coordinate care. So there's a lot of stuff on that left column. We reviewed her chart. We tried to figure out how to simplify the medication she was taking and the stuff that we were doing for her. We sent a care coordination summary after we got involved back to her primary care doc with the active issues as our care coordination team saw them in the plan, referred to the senior clinic for a cognitive assessment. And you can just see as we go down that left that there was lots of stuff that we did. Now, in the blue on that left column are places where we had to make a referral outside of the healthcare sector. So we referred her to senior services sort of as soon as we knew that this was a real issue, to at least help us evaluate and assist her in the ways that maybe we couldn't from the medical side. A little further down, we actually tried to conduct a shared home visit with our care manager of Jackson and the senior services agent so we could really figure out what was going on and how she could get through her everyday life. A little further down, you see another blue that we had to arrange for some home health services once we've done that assessment. So we're trying to coordinate with people that are outside of the medical care system. Now, how we did that middle column, is to me really informative and shows how much we struggle to do this work. In order to simplify the medical regimen and figure out what was going on, we had to hand reconcile multiple med lists, one from the hospital, some from an emergency room that wasn't in our community, some from our electronic care record. As you can see multiple times down that column, there's lots of phone calls, faxes, old-fashioned technology for people that live in silos. And the red in the middle are the places where we had health information technology to support what we did. Not very many places do you see that red. So the summary that was sent to the primary care doc was an embedded app, a care management app that we built within the next-gen electronic medical record. It took a lot of time and effort to build that, but it allowed us to make some connections to practices in a much more efficient way. We could e-schedule through our care managers to the practice, the PCMH practice. And when we did have a conversation with a patient by telephone, then the conversation about what Millie needed or what was going on could be sent through that care manager application back to the primary care doctor. But as you can see, every time we went outside of the medical silo, we had to do a lot of work. It took a lot of time, multiple telephone calls. And as you can see on the far right column, there was some exceptional effort even beyond the call where our care coordinators, care managers went to the home, and after the outside group, the home health services and the senior services agents failed to follow up on some of the things that they had committed to do, our care managers went out and did some of that work in the background on their own. So this stuff was held together by a lot of exceptional effort and by an awful lot of both telephone, some face-to-face, some other work that just made it very, very difficult to carry out. This story goes on for probably a year and a half. We've just kind of continued with Millie along the way. But you can see how hard it is to do this work by this example. With that, maybe I can turn over. This is the whole point of what we're doing here. We're trying to make sure that on the ground, we can better provide care for people who live in our communities where that care goes across organizational boundaries. And that is the fundamental sort of first thing we have to do right to make care work. So let me turn it back over. Don, maybe people have questions, but this is just a good illustration of kind of why we have to do this stuff better.
And I'll just add, what always impresses me when I hear Mike tell this story is Mike has been working in the Jackson community for many years. Jackson has done a lot of work to organize information on the healthcare side, but you can see without the community being involved in that, there's still gaps. Lauren, did you have a...
So Mike, that's an awesome example, but I wanted to break in because I've gotten a couple of texts from folks from the phone. So if people on the phone can make sure to mute your line, if you're not speaking, I think there's some background noise and folks are having trouble hearing.
Okay,
I don't know if
I'll just
do that or if people, so if you can just remind me.
Okay, I'll just repeat that. Lauren's been getting some texts from folks that are signed in via Zoom to just make sure that you mute your line. Linda, you had a...
And Don, I'd just like to suggest that folks, when they want to speak from this group, that they pass down the mic just so that people that dialing in will actually hear that. Great.
So
Is there a mic somewhere that you need help pass?
Yeah, we have some handheld mics that are around, I think. Could folks raise their hands where those are located? Okay, fantastic. Great. Okay. So, how did we get here? I mean, this wasn't because we were trying to create silos. I don't think it was anything that was ill-intentioned, but we've seen over the past certainly 10 years and longer the rise of healthcare-based electronic health records. Not a bad thing. Well-intentioned. Many community services organizations have developed their own systems or purchase systems to help them organize the information around their clients. We've seen the development of health information exchanges to try and interlink the healthcare sector side. And every time I'm in these conversations, I'm just overwhelmed at the complexity of what's going on in the community services sector. But there are groups out there that have worked to try and get a handle on that. So it's complicated, but it is knowable. So how do we get out of here? So I'm going to throw out some concepts and some big words here. The first one is socio-technical infrastructure. Bum, bum, bum. So you can sort of imagine, just by reading the term socio-technical, that this involves working with social interaction and technical side. So for folks that are familiar with user-centered design, the nerds in the audience, that's kind of what this is like. And Mike Martin, as he'll tell you, he had a previous career in the telecommunications industry, and he kind of inspired me to think about this example. So if you imagine for a moment you're making a telephone call, and you're calling somebody that you need to transact some kind of business with. You know, it could be, I had to make a phone call a while back to get to somebody to schedule an appointment to get my snow tires done. So there was some information that had to be exchanged early on. If I'm making, in the old days when we'd pick up the telephone to make referrals, or sometimes we still do that with behavioral health. So I'm picking up the phone. It's Don Nease. I'm a family doc, and I have a patient that I'd be interested in referring to you. So there's some introductions. I have to explain who I am. The person on the other end has to explain who they are. There's some conventions here that we've all sort of grown up with, so they're kind of unconscious. But we do this stuff. We establish what the conversation is about. This is why I'm calling. And, we get to know each other a little bit. Oh, how long have you been working at A.F. Williams? I've been here about 4 years, and really enjoying Colorado. How long have you been doing what? There's some of this human exchange that happens. Okay, the next time that I call that person, what's different? We've already established that, right? We've already so when that person picks up the phone and say, "Hey, this is Dr. Nease." Oh, Don's calling. He's either calling to ask me about a patient whose care we share, or maybe he's got a new referral. So there's sort of immediate understanding there. Is that what happens with health information or care information? Typically, the conversations are about, well, we're gonna take a CCD file and we're gonna upload it or we're gonna take an ADT file and we're gonna upload it and share it everywhere. So this notion of roles, responsibility, intentions, what we intend by sharing that record, are not talked about, not really worked out. So that social part of the technical infrastructure oftentimes is wanting. Now, I'm going to throw out another basic concept here. Applications versus infrastructure. Okay? Applications developed to solve a particular problem. Not a bad thing. I've got lots of fun apps on my phone. An EHR is an application, okay? So we use applications all the time. We're very familiar with that. They excel at specific tasks, moving around, dealing with specific data. They can be bright and shiny. They're often really attractive. Nice user interface design. And when I think about applications, I think about cars, okay? Cars are great. Most cars, though, are fairly well specified to do a certain task. So you got your minivan, you've got an SUV, a sedan, and, you know, you can sort of make them do other things, but, you know, I was never that crazy about getting in the minivan. So that's the way I think about this. On the infrastructure side, infrastructure is developed to enable many different kinds of solutions. So if you think of infrastructure as enabling lots of different applications. So the internet is an example of infrastructure that a lot of things are taking advantage of now in terms of applications. Infrastructure excels at providing support for multiple tasks. It's often not very pretty. It's not very shiny. It's kind of hard to get folks to want to invest in infrastructure. Could be ugly. But, you know, if we're using the car example, let's think about infrastructure as roads. Pretty essential if you want to get somewhere safely. If you want to drive your car somewhere, you're kind of dependent on infrastructure. Like my wife phoned me because she comes in earlier than I do, and told me, you might want to detour around Moline coming from Stapleton. So, applications versus infrastructure. Does that make sense? Okay, great. We're trying to promote infrastructure rather than specific applications. And we'll tell you why. All right. Mike? Let me pass this bit of infrastructure to you.
I'll try not to.
There you go.
Thank you, Don. Hello, everybody. It's an enormous pleasure to be here in Denver, in Colorado. There we go. Architecture. What does that spring to? That's the stuff that the really expensive guy does, isn't it? The architect, he's the guy in charge. I want to disabuse you of that. I want to give you a different concept of architecture. By the end of this session, I want to try and convince you that the architecture is your business. And if you don't do it, it's not going to be right. Now, this, of course, is a very different concept of architecture from the stuff the expensive guy does. It includes some of it, but it's pretty different. And if we're going to understand what's different, well, let's look at the word. Archi. Think archaeologist. Before, prior to. Texture, that comes from techne, doing technical work. So, if we look at the word, architecture is the diagrams and text that help us to talk to each other across our different technical boundaries. Now let's consider technical boundaries. There's clinical boundaries, there's nursing boundaries, there's management boundaries, there's financial boundaries, there's the technicality of managing a complex long-term condition in difficult social circumstances. This is another technique. How do these different techniques, how do they communicate with each other? Because if they don't, we haven't got an architecture, and what tends to happen is what we've experienced. The technical guys take over and dictate the whole discourse. So that's the problem we're facing, or it's one of the problems. So, now I'm going to introduce you to the concept of a reference architecture. Now, this is a really important thing, and if we succeed today, then you guys are going off and building yourselves a reference architecture. Sounds a bit scary. Okay? But a reference architecture is your shared vision of where you're going, of where you think you need to be. It's big and it's complex, and you can't jump there in one leap. And so the job that your reference architecture does is it gives you a framing for these things we're doing now. We're doing it because this part of it and this part of it will contribute, and that's going to be replaced, but okay, that's a short term. Okay? So, but you've got to have this vision, and you've got to own it. Not the technical guys, you've got to own it, because when I point to you, I think I'm pointing to the community. I hope I'm pointing to the community. So we're interested here in the information infrastructure. Don's introduced this concept, infrastructure. And of course, it's about information. So we really need to unpick, sort out this information stuff. What is it? I've got a little picture that I'm going to build here. I have to admit I'm quite proud of it. I have to admit that because it's not had a very long life so far, but it has provoked and stimulated some very interesting discussions, and I hope that will happen here today. So we've got the engineers, okay? Their concept in infrastructure is about bits and bytes. It's about signals and noise, about channels, all of that sort of stuff. Very powerful discourse, this. They can't say anything about meaning. They can tell you exactly how much, they can tell you exactly where, they can tell you how fast, how soon, but nothing about meaning. They do an important job, we're not dismissing them. Now we have the informatics view. The informatics view is about codes and terms and objects. In clinical land, this is a bit of an industry. SNOMED and all of this sort of stuff. Meaning is predefined and concrete. You define the meaning of stuff, and then you inscribe it in your system, and you use it. Don't change the meaning while you're using the system. That would be a big problem at the informatics level. Now, the sharp-eyed amongst you will notice I've made a jump, okay? Because there is a gap. And at the top here, we have the socio-cultural view of information. And this is about individuals, about values, about principles. This is where we negotiate new meanings. This is where we express and become humans, become community, we have relations, okay? That's real life. Real life. Now, the reason I've drawn it like that is I want to give you a little example. And it happened earlier this year in the UK, and in England, a bright spark in the centre of the NHS said, we're going to have care.data. We're going to apply big data concepts to all the clinical information in the NHS, and that's going to make loads of money, and it's going to be great for everybody, and it's going to be wonderful. And some people got a bit worried. Now, there's a lady called Dame Fiona Caldicott, and she's been designated by the government as the person to look to the interests of patients and citizens in relation to their information. And Dame Fiona says, I have to be assured that clinical information in care.data is going to be safe. So there's a bunch of guys down here in a place in NHS Digital, and they go, oh yes, Dame Fiona, oh, all right. Look, Dame Fiona, we have this international standard. It's got guns, it's got guards, it's got gates, it's got everything. It's got an operations manual, YASIC, and we're going to follow that manual. All of the data in care.data is going to be in a safe haven. What bit of safe don't you understand? Now, of course, this is not answering Dame Fiona's question. Because to answer Dame Fiona's question, we have to talk about roles and responsibilities. This is the conversational view of information. Okay? And at this level, information includes intentions, intentionality. Okay? So, we've got a framing here, a layer cake. There's really important work to be done at each of these levels. The bottom 3 levels, the work is systematic work. It's, you have to be rigorous in order to support the top where you are. We can't prescript, we can't systematize at that level. If you try to systematize at that level, at best it's an act of control, and usually it's an act of abuse. Does that make sense? Okay. So, using our sort of template here, this is, if you like, the most abstract view of the architecture. We're dealing with information, and we need to know what we're talking about. And we've got conversations to have at each of these levels. Some of them are very technical conversations. Some of them are less technical. They're more about practical. And we've also got conversations to take place between them. Please.
Mike, once you've got the engineering view, the informatics view, the conversational view, the social cultural view, what else is missing?
Oh, there's a question. There's a question. To answer a question like that, we have to say complete with respect to what? Okay, because you can't just complete as a sort of an open-ended thing. So for me, the discipline of putting this together has been, how do I find a home for all the different disciplinary discourses that come into play and seem to have some relevance? Okay? So in that sense, you start off stamp collecting disciplines, okay, that seem to be relevant to the problem. And the problem, of course, is, how do I build an information infrastructure? How do I talk about an information infrastructure that is expressively adequate of all the concerns and interests that are being expressed around the table? Now, I got parachuted into health and social care at the turn of the millennium from commerce and business, okay? And it was deeply shocking. I, up to that point, had been part of a disciplinary framing that produced the bottom 2 levels. It's commerce. The intentions are straightforward. We're here to do business, we're here to make a profit, we're here to stay in business. So they can remain implicit. And we built a framing of the world up below that line that said, we'll draw this line, we'll demand rationality on the inside. If we find irrationality, there is a single point of recourse, it's the management. So we can make it rational in order to deal with the opportunities and threats from the outside. This is the integrationist paradigm. And so we built an architectural discourse of function, capability, capacity. When I brought that to health and social care, it was quite clear that it was expressively inadequate, which led me to make some studies of the architectural discourse of jurisprudence, intentionality. Okay? How do we then incorporate that? And then at the top level, I say, well, okay, can we go any further? What's missing, this question? Well, okay, this is a university, we've got to do some heavy theory here. Okay? At the top level, this is being human. So we could be Cartesian. I think, therefore I am. Okay? In wonderful isolation. Okay? Or, alternatively, I could be Heideggerian. We communicate, therefore we become. Okay? Now, at that level, negotiating our meaning, negotiating our intentions seemed to be what was going on in health and social care, despite all the attempts to systematize. It's not a complete answer, I understand, but that's the discourse. Okay? So now we're going to take this and we're going to draw a picture. Okay? Because architectures usually have pictures rather than text. So look, technical transport, it's a dumbbell. This is switching and routing signals around the place. And these guys do that job. And of course, these signals are going from place to place. Okay? We're sending packages between addresses. Okay? So some of these high-paid technical people, this is what they talk about. Okay? Codes and terms, headings, and data structures. What counts as a communication? Now we come to the conversational. So the first thing I do is I recruit some figures from toilet doors. Okay, little people. Okay, it's like that because what I'm inviting is that me? Am I one of those? Are you one of those? Okay, the lines between these, they're conversations. Okay? So this, if you like, was Don's first story. We've called up for the first time. What we are an originator and a recipient, calling party and called party. Okay, and we're calling about somebody. So now we can hang on some identities. This, of course, is back down to our informatics level. Identities are just labels for things. Oh, look, it was a discharge summary. Okay? So this stuff up here that we've just added is at the conversational level. What was the discharge summary? Was it a chat on the telephone? Was it a letter? Was it a fax? Was it an electronic message? Those are the ways of implementing it. What was intended is a discharge summary. Were you careful about it? Did you take it seriously? Did you put everything into it that needed to be into it? Did you overload it with unnecessary data? Okay. Now, the job that layer has done, back to Dame Fiona's story, is that we can now put governance into this, and it's doing a job. It's not just a decorative freeze at the top saying, oh, we'll do some governance, because, look, the governance means that our originator is now a discharging physician, a role, sutured down onto the acute trust in the hospital, okay? Similarly, our recipient is the GP in the local practice, and our discharge summary was an example of a document of this sort. Okay? So, now, we're going to get some more of these little people. No architect here is in scare quotes, because these are these technical people, and we've got some architects down. These are network architects, okay? And there's network policymakers, and there's network implementers. Now, I'm an engineer who sits in a very socialite, science-oriented business school, surrounded by critical social scientists, and getting kicked and smacked and pummeled down the problem, the sort of thing, okay? But I've got to build something, and they don't, okay? So they just criticise. But they do, I don't want to dismiss them. They're wonderful people, and they do great work. And one of the insights is that, Mike, it's not just implementer user, it's implementer user victim. Okay? There are victims at each of these levels. So, and when I do these pictures, very often, hands up, are you one of these ladies in the middle? Are you an architect at this level? And people put their hands up, okay? I've had the very interesting situation of being able to say to them, do you guys talk to each other? Do you have conversations? And the answer is, of course, they have great difficulty. So, these are the guys who are doing the work in those views. Okay? We don't have architects at that level. If that's not us having the live conversation, then it's not governance. Okay? Now, when I show that picture to the technical suppliers, conventional technical suppliers, Cerners and the Microsofts and the Fujits, these sorts of guys, okay? They say, yes, we do that. We do that. As long as you keep this stuff at the top nice and concrete and give us a use case, we can do the rest for you, okay? And what they say is, we will build you an integrated enterprise solution. Okay, we'll draw a line around that. This is the hospital system. Okay, you want to talk to the GPs? Okay, we'll give you the means to do that. Oh, you want to talk to them as well? Oh, well, give me some more money and you can do that. And, oh, you want to talk to them as well? Oh, sure, that's more money. Oh, you want to stop talking to them? Oh, that's more. Because they've got a hold over the system. They own the architecture of the system. Okay? This is a problem. Nick will be telling you about some of the consequences of this approach applied at the national level in the UK. So, there's an alternative here. Rather than connect to you, connect to you, connect to you, you connect to, we'll do this mare's nest. As Don mentioned, there's this concept of the exchange. Let's put something in the middle. Let's share something because we're a community. Okay? And this is beginning to happen at various places in the world, beginning to happen in Europe, beginning to happen in your world, where people are building these hubs as an exchange. Now, we're almost at the infantile disorder stage with this. Okay? We need to grow through some of the things and we'll be healthier and stronger as we do it. Okay? So we're not going to get there in one great leap. Okay? So for instance, most of our hubs are hubs in splendid isolation. Okay? It's hard enough to get a hub mic, never mind do anything. Okay? But actually, this is a misunderstanding because, if our hubs had a hub, okay? So this is the concept of federation, okay? The idea that we can share something, we all connect to it, but whatever stage we do that, there's always somebody else in the world to connect to that's just like us. So what have we got to talk to them about? How do we connect? Okay? So, how does a hub work, Mike? Okay. Where do hubs? Who's invented this? Well, in fact, we've already got hubs. The technology, the technical means for doing this is the way the systems integrators did that. So we've all got hubs on the inside. Now, hold on, fasten your seatbelts. If it gets, oxygen mask might come down. Okay, I'm going to use a really hard word now. Okay, and I know sort of half of you, maybe 2/3 of you, have gone, oh shit, he's gone bloody techie talk again. Okay. Now the thing is that you remember the suppliers who want to keep control of the relationship. They've got middleware, and middleware is their hold over you. So they're not going to make it easy. They're not going to explain it to you. Nobody's going to make middleware simple. They're going to make it as complex as possible. Okay? So I've spent, since the early 90s, trying to explain to people what middleware is in a way that makes sense to real people. Okay, so I've drawn a Greek temple here. It's a portico, right? Portal. Communicating, publishing, syndicating, searching, discovering. You're used to that. You do it every day. This is a middleware function. The index, giving things names, saying that belongs to that. Okay? Is this what it claims to be? The switch. Marshalling and dispatching, getting things to the right place at the right time in the right order. Okay, transacting. That's all middleware is. That's what makes a hub. So how does a hub work? What does it do? So here we have our apps. Here we have our information services. Here I've got all our back office stuff. Okay. And what we've got here is a user, came off a toilet door again, and here we have a little device. And the user logs on. And what we've got now, remember this term, we've got a session. Okay? It's started. We've got an identity, we've got a role, we've got a relationship. Okay, we've got a relationship. So this isn't just me, I'm a doctor, show me everything. This is me, I am Joe's doctor, I am Amy's doctor. And Amy, or John, or whoever, has got a whole bunch of other relationships. So this session isn't just an individual, this session is making a link to a constellation of care, a specific set of relationships. And what does the middleware do? The middleware takes a bit of red stuff, a bit of blue stuff, a bit of whatever colour that is, a bit of purple stuff, and puts it in, okay? And what that represents is conversations between these parties. Okay? So that's a key issue. Just think, if those characters there are sitting around the table saying, in these sorts of circumstances, I've logged on, it's routine, I'm doing a routine review for a patient or a client like this, that you have a relationship with, what do you want to push into it? What do you want to make available? What notifications do you want? You're sitting around the table designing the session, not giving yourself a set of requirements for an application builder to go and build an application. Because in the environments that we envisage, the outcome of that conversation is the configuration of your sessions. Okay, now Mike asks a stupid question. If you say this to the suppliers, they think you've gone bananas. How does my middleware talk to your middleware? Sorry, I've got middleware and I've got a boundary. Okay? And then there's the outside world. Because I'm an integration, I belong to the integrationist religion, not the universalist religion that says everything is connected to everything else in the best of all possible worlds and we all play nicely together. Okay? You know what I'm talking about. Okay? We're integrationists because we keep things flattened down. So this is a really silly question. But let's ask it anyway. So here's our middleware. Narrowcast and broadcast publication across organisational boundaries. How do I transact across the boundary? Don't understand. Is this one of yours? Not one of mine. Okay. So this concept of middleware that we've got, these three simple sorts of functionality, now gives us a language for how middleware talks to middleware. This is key. Because look, first thing, this discharge summary. Oh, there were some sessions in the hospital that created it, and there's some sessions in primary care in which it's used. Okay, so the discharge summary as a real thing is things happening in sessions. And how does it happen? Oh, middleware that delivers. Let's make it concrete. I've got my Millie story. My Millie is called Amy. Okay, Amy is 83, older than Millie. Amy has been fiercely independent, very sharp of mind, but her sense of taste, her sense of smell, her sight's going. She's getting more and more frail. She lives on her own. And poor old Amy has fallen over outside her house. She fell over because she was dizzy. She was dizzy because she got a rather bad urinary tract infection. Got a rather bad urinary tract infection because she can't look after herself as well as she used to. Okay? So, paramedics have arrived, and she's arrived in accident and emergency. Now, I'm not going to go through, I'm incompetent, I cannot competently take you through the clinical scenario. But look, there are lots of conversations going on. Okay? It's broken neck of femur, by the way. But of course, we've got the urinary tract infection. Now we've had surgery. Amy needs some mental health thing. She's got depressed. Remember, she's bright, and she's realised, shit, this is changing things. Okay. Now we have the conversation. Okay, that is the discharge summary, and there's a whole. Okay. Now. What I'm now going to do is build another little picture, Normally when I do this, I have multiple screens. I have a room and I put things side by side. And I really like to put things side by side because people can go, oh shit, okay. And you can't do it with this. And it really frustrates me. But remember that picture when you look at this build, okay? So that's a session and there's information being syndicated into it. It syndicates some information into an A&E report, and this generates some pharmacy and path lab, remember, in the emergency room. We've got an admission. This is a session with an administrative worker doing some stuff, and there's information being syndicated into it and out of it. You know, Amy's only had to give her a name and address once, or, you know, okay? Nursing notes, we've got path lab, okay. Surgery report, okay. Rehab plans, okay. Discharge summary, so these are all sessions, okay. There may be multiple sessions, of course, where information is coming in and information is being generated in the future. And what we have here is the whole fan in to our. Now we've got primary care, right, okay. We've got a complex long-term care plan here. We hope it's a long-term care plan, okay. And there's a whole bunch of guys involved in this. And of course, finally, and this is most important, there's Amy's stuff. Okay, this is Amy's page. So that is the view of the previous set of conversations, but in terms of a set of sessions. Sessions are the things that sit in conversational relationships. Okay? So if you're thinking about your world in terms of conversations, in terms of your roles and responsibilities, then it goes to set, okay? If you're now a technical person, I need to get this information in and out and the other, I've got some requirements. So you see how this concept of the session is acting as a link between the intentional thinking and the functionality of the system. Okay, these will all be available afterwards. So there we have it. Final message here. Governance isn't following the rules and showing you followed the rules. Governance is taking the evidence that this infrastructure gives you and saying, is this what we wanted? Is this what we intended? And, you know, the answer can be, no, but shit, it's good, isn't it? Or no, let's stop it, let's change it. Okay? But the issue is that those changes aren't going back to the supplier and say, build me a new system. It's let's crank the handle and do the reconfiguration of our sessions. I'll leave it there. Any questions, observations? Stunned silence.
Session, conversation.
So, okay. The conversation is the intentional framing, okay? It is the view of the issue about who am I, what's my role, what's your role, what's the significance for me, what's the significance for you, I'm the doctor, you're the patient, okay, so there's different significances. What's our mutuality? Am I looking after you, are you looking after me, or what, okay? What's the distribution of control here? What's the distribution of resource here? Okay, so that is conversational analysis. And at that level, for example, we might say, oh, we're in a research hospital here, so we've got doctor-patient, researcher-subject. Oh, conflict of interest here, composing those conversations together. So we have to introduce some new conversations, such as the ethics committee, and some new instruments, the consent form and the protocol. Okay? But this is all quite natural reasoning and logic, okay, at this conversational level. Now, a session is an occurrence, an event in time. It has a beginning and an end. And the initiation involves declaring who you are and what the context and what the relationships are. A set of behaviours where information will flow in and information may flow out. Okay? And then the session will stop. Okay? So those information flows correspond to the actualization of the conversation. Did they do what we intended?
The conversation starts, everything it defines the relationship, and then the session is the movie.
That's right. So the conversation language is our language about what we intend, what our conventions are around here, what what we take to be a doctor around here, okay, for example. Okay, the session is our operationalization of all of that, and of course that produces evidence, which we then look at and say, is that what we meant? Under those circumstances, is that acceptable or not? And of course, you know, the participation in that conversation, the conversation of governance, is a really interesting and important political policy rights issue itself.
You use the word intentionality. You kind of construct something that we call trust.
Yes.
When folks are speaking, if you could make sure you're close to a mic, just to make sure that folks online can hear that.
Okay. Yes. So the issue there, this concept of trust belongs at this level of the conversational level. Okay.
Right.
And it corresponds at the implementation level to concepts like provenance. Mm-hmm. So a set of information comes on a screen. What is the provenance of this information? Mm-hmm. Okay. So at that level, and then you've got issues like recourse, which says, right, that's wrong. Right. Okay. Right. And then we get into a whole set of discussions, which is the next and the next but one session, about concepts like publication and editorial control and this sort of thing. How are those concepts relevant or not in these sorts of concepts? Mm-hmm. Okay. Please.
Okay, so Scott Hammond, Westminster Medical Clinic. Seeing that there's probably a big gap between going from, if you move from engineering to informatics up that route, there is, at least in this country, seems like it's going to be many years with many barriers. Is there any way to start from the socio-cultural and communications end and kind of back your way into this system? Because otherwise we are going to be waiting a long time for people to sort out this infrastructure.
Okay. So the way you have phrased your question is based on our experience across the world about the dominance of the technical discourse at the communications and the informatics level, because you know the way the economy and the way the sector has gone, they seem to make loads of progress in commerce and business. Let's make health and social care like that. Let's make it more business-like. Okay? Completely naively misunderstanding the complexity and the intentionalities of health and social care. Okay, so you know there are a small number of us who've been struggling for a long time to say, hey guys, there's a problem here. That the architectural discourse that we have constructed, which is based on function, capability, and capacity, which does wonderful work, you know, and it's beautiful stuff, but all it will do is solve puzzles. There has to be an answer, okay? You guys are dealing with problems, now, and often wicked problems. Now, for me, we'll go back to Descartes and Heidegger here, okay? Just so you don't get too comfortable. You know, Descartes, you can solve puzzles and you can do it on your own. Okay? Heidegger, that's about we can only do that together. Okay? We could. Pardon? Getting very heavy shit now. I'll see you later. Any more questions, issues?
Yeah, this is Mike. Hi. I just want to maybe answer the question in a slightly different way. I think the answer is yes, you do this by working in the community to start to have conversations between the people who have come together to make the care in the community better. And there's no other way about it. You just start to say, this is what we're trying to get to. it seems like the way to get there is to begin by talking amongst yourselves, understanding what it is you intend for your community to do and how you can facilitate it. I mean, that's back to the question on the top of this very slide. We intend to bring care together across the boundaries that we've not been able to cross.
Yes.
And let's figure out how to do that. It takes time. I've been working on this in Jackson, Michigan for some time now, but there's no shortcut. But those conversations have to happen before you get the technical folks together.
I'd strongly endorse what Mike's saying. You have to have these conversations. Remember where I started. You have to have these conversations. The conversations are at all the levels. You're not all interested in all of those conversations, but okay. Those conversations need to produce an output which are representations, which are pictures. At the bottom, we see pictures of, your environment, your networks, your physical, okay? You see stuff about, your messages. One of the things, these characters here, down at the bottom here, okay? One of the things that we've found, and it's only preliminary, and so you have to take this up and appropriate it and cannibalize it and make it your own. I'm not telling you how to do things here, but this idea of struggling round, we call it Amy's page, with practitioners saying what needs to go in here, what needs to go out, because I'm in these circumstances, for these sorts of cases, okay, is very, very constructive work, and it produces an output which can be analysed and produce quite powerful stuff. Now, okay, so these people around here, for you guys, the financial controllers and the payers will be around that table, okay? So you ask me the question, where's the financial control in your architecture, Mike? It's not my architecture, it's your architecture. And the financial control is part. So the financial controller might say, I want all items that have a cost that go beyond budget to be greyed out. Well, so you can't spend above budget. And the clinicians look at it and say, shit, no, that's not acceptable. So the architecture isn't solving that problem. So this community might take a particular view now, which is a different one from this community. And this one may change it next year. But the issue is that's the reality of the community of care governing itself. And of course there are all sorts of constraints coming in at the national level and the state level and all this sort of thing, which are all part of it. Okay. But the issue is moving from the ability to have these conversations to the configuration of the system to deliver the intended conversations, okay, to the information to require, has it delivered the conversations, do we want to change it? And this is, I suggest, a completely different paradigm from the give us your use case and we'll give you the system. And then we'll configure you to it. That's the victim thing, yes. Yeah. So, go make yourself an architecture, come on.
Okay, next we're going to hear from Nick.
It's on now.
So to me, Mike's saying, draw your own roadmap, get a vision, and do some leadership, because the roadmaps that we've been given by the suppliers don't make sense to us as to where we want to go. So I'm just going to, I'm a GP from Northumberland in the north of England. I'll show you a map later. And I've been interested in IT and health informatics really since I first started as a general practitioner in the 1980s. So I'll talk a bit about that. I think in order to understand what we're doing in the UK, you need to have a revision session or a crammer session on what the National Health Service is. Then I'll tell you about my first encounter with Mike and with architecture in the Durham EHR project, which was in about the year 2000. I have had a headache ever since, but I seem, even today, seeing Mike's diagrams, I think more and more about it, and it really is important to stick with it and get that roadmap built. After I left working in the university with Mike in about 2003, I left to do some commercial work in the English National Programme for IT, which I'll talk a little bit about. And then towards the end of my career, I spent 5 years in the Department of Health in the government and in the information standards regime, NHS Digital, and that was quite hard work and somewhat painful. And I decided that I would spend the rest of the next phase of my career trying to work out what happened. And now I'm privileged to be working in Newcastle University again on a project called Connected Health Cities, and I'm going to talk to you about that. Okay, so I was really sort of interested in getting a computer when they first come out. I bought a EDC Model B computer when I finished my training and I could afford it. And I joined a practice and I thought, well, there's some aspect of this practice that we could computerize, so I built a pap smear register and we ran our pap smearing clinics off it and it was really good. And then we were lucky enough to come across two companies who were offering multi-user electronic health record systems designed by GPs for GPs, running on Unix, which were free, and they sold the data to drug companies. And those lasted for about 2 years, but 2 years was enough to get our system up and running before the whole shebang went bankrupt because the drug companies couldn't really understand what the data was all about. It didn't have enough context around it. And so we had to buy the system, but by then we were hooked. So at that point, being a new GP and having the ability to show what a GP system could do for managing a practice and improving care, using data, forming cohorts, examining what you do, what processes you did, what were the results of those processes. Not very much, let's change them. Improve the diabetic care. We were well onto the way of understanding what digital health meant. And it's an amazing fact that in 2016, I don't think many of the hospital doctors in the United Kingdom anyway understand what digital care is because they don't get hands on any data about their patients. So we've got a lot of work to do. After 7 years in the practice, I went and did a sabbatical with James Reed, who invented the Reed codes, which is a way of creating numeric concepts, basically, which embody medical concepts, and you can manipulate them on computer. By now, 100% of general practices in the United Kingdom use Reed codes, and we're just about to change to SNOMED CT. So in 1999, Reed and SNOMED merged. College of American Pathologists and the UK government did a deal. We created a new organisation which invented SNOMED CT. And that's about to be implemented in general practice next year. So all of the Reed code systems will be changed to SNOMED systems. And in 2018, that will happen in hospital sector. I think we'll manage to do this in general practice because we all use these computers all the time for all our work, and they're quick, they're good. I think there's an argument to say that general practice in the UK is as well computerized as any health domain in the world. There's arguments in different countries in Europe, but basically it's so commonplace that general practitioners no longer think about it. It's just part of the infrastructure of the practice. There you are. Remember how I used the word infrastructure? I then left and went to academic general practice informatics, and we built a decision support system. We did it collaboratively with Stanford, over here in Stanford. And then Mike and I joined together on quite a big project to create an architectural understanding of large-scale health information systems and how they would work, the Durham and Darlington electronic health record. And after that, I left, joined the commercial world, worked with Capgemini Ernst & Young for a year, bidding for a contract in the national programme, and then working for British Telecom in London, where they put in the hospital systems and also put in the national infrastructure. And then 5 years in the Department of Health on information standards. And then back to Newcastle University doing this Connected Health Cities project. The Great North Care Record is what we like to call it, because we want to make a brand which patients understand and trust. So, revision on the NHS. The health service in the UK is free at the point of care. Nobody has to pay for it. There are some small co-charges for prescriptions and contributions to dental treatment, but more or less everything is free. It's funded from UK taxation, and there are actually 4 national health services in the United Kingdom, one in England, one in Scotland, one in Wales, and one in Northern Ireland. So they're all managed separately, but have got more or less the same principles. And in England at the moment, roughly, there are 156 acute hospital, community and mental health trusts. They're either acute hospital, community or mental health trusts, or some combination of the 3. 210 clinical commissioning groups, which is the primary care system, and they also are organised into groups so that they commission care on behalf of their population from the hospital sector. So they're independently governed health organisations. They're not some kind of vertically integrated pyramid where everybody obeys a chief executive. They're more like a bunch of organisations in equilibrium. The management science that dictates how you understand the NHS is probably called anthropology. And there's no real vertical integration or accountability at that level. Parallel to it, there is some private healthcare, but it's not a full integrated system. So basically, people go in there for single planned issues of care, but very rarely for complete care. And if something unexpected happens, they need to revert to the NHS. We love the NHS. Most doctors have got no hesitancy of using the NHS for all their care, all their family care. It's a well-loved institution. It's under a bit of threat, but we're sticking with it. I've got a badge here to prove I love it.
Nick, I might interrupt. The point of that, what Nick just walked you through, is to hopefully disabuse folks of any notion that the National Health Service in the UK functions as an integrated, vertical sort of operation. There are many of the same siloed sorts of issues that we deal with here.
Okay, so Wales, Northern Ireland, Scotland at the top, England at the bottom. The border, if you look at the Isle of Man and think of it as an arrowhead pointing to the north-east, the border runs basically along that line. And I live approximately where the E of United Kingdom is. That's where my home is. So, in 2000, this is Durham. That's Durham Cathedral and Durham Castle. It's a very old city. The cathedral was built in 1100 AD, and the castle was built more or less the same time to protect it. And that's Darlington. So that was a community that wanted us to show how to integrate care. And that was 16 years ago, Mike. It's gone quickly, hasn't it? And we managed to show that an ecosystem of messages which serve purposes, just like Mike has expressed as conversations and instruments of conversations, was sufficient to create a virtual health record. And we built a replica of that virtual health record, and we showed it to clinicians who'd helped us design it. And they said, yeah, that's good. We could use with one of those. And then the national programme came along and threw away the jigs. So what I learned from that programme is that we've got an intense problem at the socio-technical interface between care and technology about language, multidisciplinary involvement, understanding one another, user-centered design. We did discuss and discover what interoperability meant at a national or regional level. And I think before they destroyed our project, the national programme failed to understand that. And we understood the significance of infrastructure. So there's a phrase here which I threw out at a meeting in Durango last week, and it was reported back to me that nobody understood what I was talking about, which is that infrastructure eats culture, then strategy for breakfast. So we have a saying in the northeast of England anyway, that culture eats strategy for breakfast. What that means is okay, have a strategy, that's a good idea, but if you don't at the same time change the culture of your organisation, it's not going to happen. And all I'm saying is that you can have a culture and a strategy, but if you don't have infrastructure, nothing's going to happen. So that's why what I think we're exhorting you all to do is get some leadership, get a vision and build some infrastructure. Get a strategy, a vision and infrastructure. So this is an interesting thing. If you grow up in an organisation like a general practice and you put computers at the heart of that organisation and you learn to run it and you can see patients and monitor their care and improve things as a collegiate group, this is a very inward-looking thing. And if you send letters and get letters, that doesn't interfere with your database, with your patient record. You just work better inside, but you've still got this relationship outside. But when you start to want to communicate in a community, you've got to change your mindset, and you've got to say parts of these records, which are patients, and they belong to patients, we don't want them to leak out, we've got to publish them. We may narrowcast publish them to a receiving physician, and they might narrowcast them back, or we might broadcast them to a safe organisational framework which says, if this patient has an accident or an emergency, this record is available for you to view. And there's information governance about that. But the change from inward-looking to outward-looking is profound. And actually that is the stage that English general practice is at the moment. And as Mike says, the hospital doctors are still on the nursery slopes. And when you start doing things, these concepts, which grew up with Mike and me, of a joint act of publication, I'm going to send this to an emergency record. Do you agree? Yep. I'm going to summarise what's happened to you and refer you to another doctor. And when I do that, this referral letter will go to you. And at the same time, I'm implicitly saying the new doctor is going to take over your care until he's done what he needs to do, or needs to do, and send you back. And as I alluded earlier, if you collect all of these transactions as people move from one organisation to another along pathways of care, then you can create a record from that substrate, a virtual health record, and we've proved in Durham EHR that you could do that. And if you've got a good presentation layer, it looks, to all intents and purposes, like a community medical record. So documents, views, sessions, all come into a virtual record, and you can make that look like a community health record through infrastructure, not through an application. And in all this, patients' data is being moved, it needs to be moved, and they need clarity, openness, and choice about that. Okay, so move on from Durham EHR, where we discovered those things, to the national programme. It was a big project. 13 billion, yes, that's with a B, over 10 years. And I worked in an organisation that had £5 billion worth of that contract. And it was amazing to see what confusion appeared to be at the heart of the organisation on how to spend that money wisely. I mean, they got their act together, to be honest, and they did build a national infrastructure, and they did build applications which worked. But as I indicate at the bottom of that list, the acute hospital systems and the interoperability part of the deal didn't really materialise very well. So now we're in a world which has got all of these things like shared imaging, electronic prescribing, an electronic booking service, GP records which can actually send entire electronic records from one system vendor to another and reconstitute the record. That's an amazing thing to see. That really is a world first. NHS email, well, that's email. But the acute hospital systems and interoperability need some more work. Have I put that in twice? Yes, I have. Oh no, sorry, I'm pressing the wrong button, sorry. Okay. Okay, so lessons learned in the national programme this time. Clinical content is critical. The forms and the sessions and the screens and the summaries need to be coherent across your community of communication. So, in our case, across the country or the region. But for you, in Colorado, that level of coherency should be striven for. Clinical data and clinical data flow should be designed from the start. It's not enough to shift effectively facsimiles of paper. There's no point just sort of making a paper-free service if you don't collect the data. The data is crucial. You've got to build in the data right from the word go, and data has got structure. Structure in health data is not well understood by the technical communities who sell us systems. Clinicians and patients are the true customers. In the National Programme for IT, hospitals were called acute service recipients. And the real customers, the clinicians and the patients, just worked in the hospitals. They had no relationship at all in the deal. The customers need to be clinicians and their patients. Technical standards are important, but clinical content standards are fundamentally important. You've got to bind the two together. Otherwise, data coherency doesn't happen. HL7 is not enough. You've got to bind it to clinical documents which make sense, clinical sessions which make sense and are coherent across the world that you want to informatize. So that doesn't mean you've got to change the systems. It doesn't mean you've got to all get Cerner and Epic to adopt a new medical model. It means you need to have a medical model and they need to understand it and write to it and read from it. That's in your clinically designed message. There needs to be a reference architecture. We need to have a vision and a consistent strategy to build infrastructure. And we can start building the infrastructure in small steps. We don't have to make the infrastructure all at once, but we do need to follow the roadmap. And Mike's given us the roadmap. So then I went to the NHS Department of Health and Social Care Information Centre, because I thought, well, maybe what I've learned on this journey, I can try and help from the top down to make some sense clinically of this. This is a clinically, not a clinically rich organisation. Let's try and improve that. And I did that for 5 years. I was the Director for Clinical Information Standards Implementation. Those are the kinds of things we did. So, SNOMED, HL7, HL7's new baby, FHIR, IHE. This is about programming the portal and the hub, the middleware. It's about finding documents. These are clinical standards. One of my jobs was to get the Academy of Medical Royal Colleges in the UK, all of the medical colleges, to agree on standard documents in English, not in computerese. The start of getting coherent information flowing. Professional Record Standards Body is an institution. It's a social enterprise which consists of all of the medical royal colleges and nursing, social care, patients, all relevant organisations who can say, don't take a content standard in your organisation and change it for local use. All of these organisations that you think are important to you and your profession have agreed that this is the standard. Join those standards up to a technical artefact, transfer of care work, that's beginning. Hopefully we can use that. So then I took a few weeks off, got a bit bored, got offered this job. The Chancellor of the Exchequer, the guy with all the money in Treasury, thought, wouldn't it be a good idea to give some money to the north of England, not London for a change, to the north of England, to stimulate economic growth? And why not use the healthcare sector to do that? So this is a very unusual funding route for us. And he gave $25 million to 5 projects, and I was asked to be the Chief Information Officer for the one in the northeast. And we got 5 million. We've got 3 years to spend it. We can't spend it on infrastructure in total. I mean, if we tried to spend it on infrastructure, it would be a drop in the ocean. But we can spend it to illustrate the kind of infrastructure that the roadmap shows us, the reference architecture. And in order to do it, with a 3-year project, with the risk of after 3 years it just sort of finishing, that was it, fizzling out, we've created a sustainable brand called the Great North Care Record. So it's the long-term vision of the Connected Health Cities project, and it's a brand upon which we want to create the trust of patients about the care of their data because they have been betrayed by care.data, where large lumps of data seem to get into the wrong hands and unfortunate things happen. So there are 3 main objectives of this project. Join up frontline care information so that everyone can see it, who needs to see it in the care of a patient on a care pathway. Create a common analytics platform for the NHS and the 5 universities and social carers in the northeast of England. And create a social contract with people and patients of the northeast to say, look, here are the projects which we want to use your data for. One of them, we're sure you'll agree, is to join up your frontline care. Don't you already do that? Well, we don't do it very well, but we're going to do it much better. And we've already started to deliver that. The next thing is to say, let's create some discussion between ourselves and the population of the northeast with citizens' juries, which is a way of getting maybe 20 representative people into a room and discussing the medical uses of medical information in research, see what they find acceptable, see what they don't, move on a bit, start getting them to get involved in dynamic consent, which allows them to give consent in outline and get informed about projects as they proceed and be able to withdraw or increase the consent for their data. And then finally, and we don't know how to do this yet, but we're working on it, create a citizens forum or maybe even a citizens council which can produce some kind of document which it exhorts patients in our region to say, yeah, we go by that. And if we're not quite sure about it, we can go onto a website and we can tweak the permissions about the use of data. So that in a nutshell is what the Great North Care Record is doing, and we're in the early stages of that. So it's not a technology project, it's about culture change. It's about asking people who work in organisations on technology and patient care to change their view. Patients live and citizens live between organisations, not in organisations. And if they get care these days, it's usually given by multiple organisations which they journey through. And if you look at architecture and design from a regional perspective rather than an organisational perspective, you get a different architectural result. We need to change the governance so that it understands that change in perspective. We need to engender citizen trust, as I've said. We need to build a vendor-neutral platform with shared services on it, which are jointly owned by the community of organisations who look after patients, either in health or in care or social care. And maybe we need to create a jointly owned legal entity to do that. So what we've done in the North East is find all of the focuses of governance, chief clinical information officers, chief information officers, analytics experts, information governance experts, communication and publicity experts, people who are setting the short-term objectives of interoperability, even the chief executives of organisations, and together getting them to talk about the concept of the Great North Care Record. So that one day, maybe not too far from now, there will be functional organisations across the region whose focus is the governance of the Great North Care Record, which they will adopt and build as a piece of infrastructure. So that's the Tower of Babel, and it's a bit like that at the moment without the Babel fish, and we've got to get the people together in the Tower of Babel or from the Tower of Babel and get them to talk the same language, like Mike says, like what Mike says. So you see we've got a varied community of vendors, not too dissimilar from what you guys have got, except some of those are UK organisations. It doesn't really need me to say, but we're not saying change your standards inside your systems, guys. Learn to understand our community information standards. So it's an infrastructure. Oh. It's gone off at the best bit. No, it hasn't. It's just gone off here, sorry. Okay. So the northeast of England is the fulcrum, the crucible of the steam engine, the railway industry. The top one, George Stephenson designed that in the 1780s or 90s, I'm not sure which, to haul coal around a coal yard. And the bottom one is Stephenson's rocket. And that hauled coal from Darlington to Stockton, hauled people. But these were just organisations with steam engines. They didn't use standards, they did a bit. The axle width of most of the trains was 5 feet. And if you go to various Roman sites, you'll find that there are furrows in the stone roads about 5 feet apart. It's just the width of the hips of an ox. But when people got a vision about what does this mean, this new revolution in steam locomotion, they adopted standards, they understood infrastructure, and that is the European rail network, all of which use exactly the same infrastructural standards. And that is the new planned high-speed 2 rail link between the north of England and the south of England and the north of England, which runs on the same infrastructural standards. But, you could put Stephenson's rocket, if it had the right gauge, on that railroad and it would work. It might get in the way. So what we need is leadership, a vision, full consultation. How do we design this? This is our vision. We want to get from here, the coal yards of electronic health records, to here, an international infrastructure where health information can flow. So that's my bit, and I'll be happy to answer questions.
So you're in the formative stages now. You're surveying your community to see what they want, how they would participate.
Yes, so we've got groups of people. I've got a group of chief information officers and chief clinical information officers who are looking at the architecture and consulting about what they want to do. We've got a group of experts from universities and analytics experts in business intelligence who want to understand the data and share a platform amongst them all. We've got an information governance group which is looking at the rules, the laws of information sharing and trying to incorporate that, bake that into a platform. And we started consultation with the public. But we're early days yet, yeah. So we've got...
How are they feeling about it so far? I mean, is it positive?
there's an enormous amount of. So we had a launch about 2 weeks ago. We were going to have a launch in April, but then they started having polls and things for Brexit and stuff. It dislocated us a little. But we had a fantastic reception at our first meeting in September, and 150 people. Very, very positive results from the feedback. Yeah. But we've got a lot. It's not going to be an easy task. This. I mean, I think we'll be lucky if we get there. But we all want to do it. Yeah. Yeah.
Can you expand a bit on how you standardize the clinical content of the information going back and forth?
Yeah. So we let so when I was in the Department of Health, we gave a contract to the Royal College of Physicians, competitive contract amongst clinical colleges, and they said that they'd done something like this before, but this was specifically a precursor for computerized traffic. But it's definitely in the domain of clinical land. These are not technical documents. But what they show is that for all of the different use cases of sending documentation between organizations for healthcare, there's a kind of common core of information. And I think that, so they do that by just having groups and, crowdsource information around topics like referral, discharge, admission, out-of-hours care, things like that, and achieve a consensus. And then basically about 2,500 people collaborated in the work, and they created this consensus view, which was signed off by the colleges.
So you mentioned that there was $25 million initially, and that was divided into 5 groups. Mm-hmm. How are those groups working together is one question that I have. And then how sustainable do you think the model is that you're developing where you are? And then how could you replicate that in other places?
Yeah, so it's a difficult ask. Four subregions of the north: northeast, northwest, Greater Manchester, Leeds, and Yorkshire and Humberside. So basically, divide the north of England into 4, mm-hmm. and then the 5th one in the middle in Manchester is the coordinating centre. Mm-hmm. So they try to coordinate what we're doing, and ideally there will be a regional hub in the northeast and another one in the northwest. And it will federate to another hub at Greater Manchester, and in theory that could federate to an English national hub.
Gotcha.
So that's how it would be. But to coordinate all this work is A, fundamentally important, and B, very, very difficult. And you can see why organisations like NHS Digital, NHS England work in silos. Right. Because it makes you work really, really hard, almost feels impossible if you've got multiple stakeholders and outside organisations. But if we don't break down the silo walls, we're doomed. Doomed.
The problem's too big.
Yeah. Well, but, I think I go back to the coal yard rail infrastructure analogy. If we take the reference architecture and say this is what we're going to do, and everything we do is going to work towards this infrastructural target, it's an achievable aim.
So, thanks, Nick. And how's everybody doing? I just want to check in. A lot of dense information. See a few thumbs up. That's good. So, we're going to transition to just a few slides from Mike Klinkman in Michigan to talk about how Mike's tried to do sort of the basic ground level work to prepare for this kind of architecture and infrastructural work in Jackson, Michigan. And Mike, I can advance the slides for you.
Don't do it yet. We'll just start with this blank slide, if that's okay. Everybody still hearing me?
Yes.
Okay. So I want to pick up on something that Nick just said. This is difficult work. And we're starting from the perspective and the context of a fairly small community, and the work is humble. It's not national in scope. So I'm going to walk you through about 4 basic points about Jackson, Michigan, and how we've started to do this work before I show you the couple of exhibits that I'll get to. So Jackson is a community of about 30,000 people in a small city, surrounded by a county of about 150,000 people. These are mostly small rural communities around a small city. It's a Rust Belt city in Michigan, which means that it's struggling. Before I ever arrived on the scene, the community had done an awful lot of work to organize itself, to try to make itself a more appealing place for people to live and work together. So with some funding and some vision from the Central Health Network and the small hospital that was in the Jackson community, that small hospital became a health system, and that health system funded work to create a health improvement organization, to think about how to link public health to the health improvement organization, and then created this thing called the Jackson Health Network that was a provider-side integrated network that would also link very closely to health improvement organization, public health, and then the hospital. So a lot of the work to bring people together to become a community of solution had already been underway before I was invited to come and talk to them about work I'd been doing on behavioral health integration. Collectively, that group, with some help from me and very good community leaders, has thought about a care model for the people of that community in that county that's clinical but integrated. So it's not simply making healthcare more efficient and care delivery more efficient. It's linking the behavioral health, community health sector in a model that is supposed to be holistic for a person. We have struggled with the ideas of connecting information via apps, but found that we could not afford the essential connections that might be necessary to connect every information tower in this community. So we decided that we could build some things into the electronic health record so that care coordination and care management from the medical side and the behavioral health side could be at least at some level connected, because we simply couldn't afford to connect an application for community care, another application for behavioral health care, to the silo of the medical side. And then finally, we've been looking for pockets of funding every chance we got to advance this idea of connecting people to care. And we came across early grants that could fund pieces of this from, among other places, insurance companies. But finally, with the onset of the possibility of managing the Accountable Health Communities program, we decided not to apply to that because AHC wound up being, again, too narrow and too constrained. And our own state innovation model and how Michigan intended to implement STEM. We've been launching and working alongside the STEM leadership in the state to carry on some of this work as a kind of a pilot test for integration. So with that in mind, we're a small group of people that are trying to work across boundaries, advance things, first work locally, and then later can connect regionally or in statewide ways. And we have a couple of things that we've put on the table in working with our state's health information exchange, our state's health information officers, and with some of the other stakeholders around our state of Michigan, including Medicaid and some of the community-facing agencies like United Way and our 211 systems. So Don, if you just want to move that next slide. We talked a lot and eventually came down into having to deconstruct things so that we understood what health information technology needed to do to serve this kind of an enterprise. And as you can see there, we've come down to 3 basic needs or functions. Intelligence at the top left corner is really talking about things that are fairly well known now on the medical care delivery side. Predictive modeling to find out who might be at risk for some bad outcomes. Registries to try to manage populations of people who have certain conditions more effectively. Notifications, meaning let's tell a clinical provider when something needs to be done for someone under his or her care. The little red underneath that is just the places where that intelligence function can be carried out and what's necessary. In this case, an electronic health record can provide some of that. A clinical data warehouse can provide some of that. And the concept of a hub moves that ahead when ready. This is where many of the places I've been working with our own statewide SIM demonstration have gotten stuck. They talk only about predictive models and registries. They only talk about using the data that we currently have to find those people at risk and make them better. But it's still strictly a medical enterprise. On the right is the second thing that we turn to most quickly, which is how do we report and analyze data? How do we find out whether what we do saves money or leads to better patterns of utilization? How do we track what services get used? How do we better report out our success in meeting quality metrics and state dashboards? That's a reporting function that is also really important to know whether or not you are moving the dial for your community the right way. But if you go to the bottom piece of this slide, this stuff is what we don't talk about. And this is exactly where Nick, Mike, and Don have been kind of focusing our attention today. It's the stuff that lets us weave together systems and people to support care for an individual person. And it's simple stuff, really, but it's stuff that we can't do right now. It's making sure that if we have information that we can put into a pot somewhere or share, who can share it? How do we make sure that it's secure? How do we make sure that the right people with the right permissions can use that data effectively to take care of people? It's really important to make sure that this is a place where caregivers can communicate across silos to make sure that if Millie Jones needs care, you can communicate about it. Remember that when I showed you what happened and the exceptional work that had to be done just to connect the caregivers that were outside of the medical enterprise, that function is missing but necessary in most places. Messaging and alerts, things that are going to tell us about when Mr. Jones needs something or Mrs. Jones needs something. A simple closed loop referral system so that if you need some help from outside the medical system, how can you make sure that you send that request and that request is answered? Yes, we can provide that. No, we can't. Yes, we did provide that, or no, we didn't. You can see the other things, summaries, simple assessments, doing community-based outcome assessment or monitoring that doesn't have to live within the electronic medical record for people that are receiving services outside of the medical environment. These things are really critical to do. They're simple, but they mean that we have to work outside of silos to make things happen. As we started to think these things through within our own community in Jackson and then sharing those things with some other communities in Michigan, we were able to begin working with our state's health information exchange providers, MyHIN, who can provide some of that care support toolbox so that we can begin to build these care support infrastructures. But that's the technical side. You know, that's an active care relationship service so that we know which clinicians are involved with the patient so that we can then say these are the permissions to share information for these people. Sending off ADT summaries. Having a provider directory that then allows you to understand who the providers are and who the patients are within a community. Small steps, but necessary. And alongside it, if behind me on this big whiteboard is a set of all the stuff that we have to do within a community to have the conversations of how to build care support in people. We've got 25 different tasks for this community, the pilots of the things that we're trying to do that we can begin to connect the simple pieces of this care support infrastructure to demonstrate that the concept holds and that it's useful to the people within the community. And that is very painstaking work. So, Don, if you advance the slide, I'll show one more thing before we talk. This really complicated thing is the Jackson version of what a community health information hub might look like. At the top left, you've got the medical enterprise and its current solutions. We have places currently in existence that the electronic medical record supports these capabilities to deliver information and communication within the medical enterprise. But the trick comes with the other two boxes. The box on the top right is the fragmented infrastructure in our community's behavioral health networks. So we have community mental health that has its own database platforms that work fairly well within each individual community mental health shop. But you can see there are many other private behavioral health providers who either don't have information technology or who have their own one-off application that provides information technology for their internal work. And connecting those becomes an important issue, but requires many, many conversations to find out what works for the people who receive service and the people who give service to link the other things that may be happening for the people they serve. And the bottom shows the much more complicated still set of community services which have minimal information infrastructure technology support, and which we are trying to bring together to talk about how you can take what you're doing now, but work within a hub, as you heard from Mike and Nick, so that your services and your needs and referrals and services that are provided can be brought into a hub so that the data and the information and the communication can happen. We're a long way from finishing this, but we have found some attractors on the behavioral health and the community services side to begin having those conversations within their domains and their networks so that we can come up with an approach that works for these service providers. We have found really great help from 211 Service and United Way in this particular community. But as you can see, there's lots of work to go. So these are the models that we're working from with a community that already has kind of pulled itself together to try to become a community of solution. And this is very, very, very hard work. But if we have to be working toward a architecture and a model for how we're going to do this, otherwise these bigger issues never get solved. I think I can leave it at that. There's a lot of stuff we can talk about, but it's probably better in a conversation form than in a lecture.
So, questions for Mike? Mike Martin.
Thank you. This is more an observation than a question. Could you go back to the previous slide? See, it's really interesting that they've made progress at the top ones and they need to do stuff at the bottom. But the reality is that the bottom should be the one that's applying them. Okay. Now, back in the 1970s, in the computer industry, we built the first generation of management information systems, and it was basically people with clipboards going around collecting information, and it was a waste of time. The next generation, we made the management information a side effect of doing the business, and suddenly it made sense. So this is the issue. The stuff for the intelligence, the stuff for the reporting, the stuff for the governance has got to be a side effect of delivering the care. And if you hear the clinician saying, coding is an overhead, I haven't got the time to do it, then you've got to look much more closely at what the conversation's going on here, what are we trying to achieve here, and how are we trying to achieve it.
Yeah, and let me jump on to what you just said, Mike. I think that we have focused for so long in the medical enterprise on intelligence and reporting that we had to try to turn the bus around in the communities. But the voice of the community at large, or the voice of those agencies and service providers that aren't medical, have been really distributed, small, not organized, to be able to say this care support tool is important, not just because we'll be able to talk about healthcare for patients, but because we have missing, very, very important missing data that in our medical enterprise, we don't have information about social issues that people face, and we don't have good information about the behavioral health care issues that people face. And until we design the care support tools that work well for us, we're going to suffer by not having that information systematically available. Not everybody gets into the medical enterprise and has that extra stuff automatically or correctly or in a valid way recorded. So you got to figure out how to do the care support right at a very basic level in order to improve your intelligence and reporting functionality. And that having those conversations now in three different communities in Michigan, we've gotten lots of interesting answers, but eventually people begin to understand that concept.
Arthur.
I agree with what you're saying, Mike. And I think that it's one of those things where you start to look at the problems and you realize you're missing answers, you're missing pieces of the puzzle. And that makes perfect sense to me. When I had this conversation with a buddy of mine in California, he gets to this care support level that you're talking about and looks at it from a different perspective, in that he believes that the folks who are in that particular area don't have the power to make the changes to the system that they would like to see. And that seems to be another part of this whole dynamic that's going on, right? That somehow empowering community, put that in quotes because I'm not sure exactly how you want to define that word, but empowering the community to do this bottom-up conversation and this bottom-up change seems to be the point at which we're stuck right now.
And I'd just jump in before you, Mike, and say what we're trying to advocate for is that if that ground level work, if that care support stuff is designed around an infrastructure that can support sessions rather than applications that are rigid, designed for a specific use case and not easily modified, that could, I think, get us closer to what we're looking for.
So, yeah, what Don said. And let me add one more thing, and maybe a good, maybe practical example. We have invested some resources from our CTSA's Community Engagement Corps and some other outside funding to start to stimulate the community conversations and to build up that community voice by describing people's current experience of healthcare, their impressions about where it goes wrong, providing a similar set of experiences from the medical enterprise and the behavioral health enterprise's side, so that we can collectively as a community say, this is what we think is wrong and what we want to do about it. And that is a very important first step to designing the infrastructure that can meet what the community has articulated as its needs. So yes, you're absolutely right in terms of it needs funding, it needs support. We have now presented to the state of Michigan a plan that will provide that support over several months, probably essentially the rest of our SIM demonstration, to build that community voice in the SIM demonstration communities. We don't know where that goes. We don't know exactly what the communities will decide, but we're trying to help give them a blueprint so that they can begin to do this organization. But I think that the important other point is that you build to a common infrastructure so that the region's decisions can plug into something that is then achievable, feasible, and scalable. So a care support set of tools and a care support infrastructure that is supported by a statewide health information exchange shared services unit can be a utility, so that those hubs can be created and so that they can be federated, so that communities, regions, and states then can share that information and learn together how to make care better. This also fits in Michigan with the idea of the Learning Health for Michigan collaborative that has grown up alongside this project.
Mike Martin had a comment.
Can I just make another observation here? Right, to take this to the next level down in detail, right? Because at this level, it's very important what we're all saying here, but it's rhetoric. Okay, it's what we want, it's what we would like, but we're not being concrete about it. Now, a lot of things going on at the moment. We hear people building apps, and then we get people together and they make their shiny out as efforts. Okay? And you technical guys, they are making an API for every app. API, application programming. It's the way the thing connects to the rest of the world, connects to the system. Okay? And they invent an API for every app. And we're not making any progress. Now, what I've tried to say is, in the early to mid-80s, we invented middleware for the first time. Okay? We've got this set of functionality, and it's pretty damn stable. It's not changed for a long time. Okay? What the guys have forgotten is that this is the canonical API. This is the generic interface to the system. If you go through a set of standard middleware type functionalities, then that's the same as everybody else's. The functionality is there. Okay? But it's been forgotten. So, there's two things going on here. One is doing the work around the table, designing your apps together as a community, and that's the way you're doing your empowering and your engagement. Okay? And it includes the financial people, it includes the management people, it includes the patients, everybody. And it may not be everybody at the same time, you've got to orchestrate. It's hard work facilitating this process. And look, and this is what those guys did. Oh shit, and then the fact was, it's hard work. Okay? But then your technical guys have got to respond to it with a very technical response that says, look, we've got these hooks, we've got this standard API, we can use that. Now the payoff here is that you're releasing the local creativity and engagement, but the systemic requirements for security, for safety, for availability is being inherited by the infrastructure. That's what the infrastructure gives you. So you're getting the best of both worlds. Now the fact that you completely disenfranchise the current supplier community and they're really pissed off, so you've got to deal with them. So there.
So I just want to check in with folks that are online and see if they have any questions for us. We're really kind of moving into the discussion phase of this. So anybody online who has a question for any of us?
No, thank you. It's great information.
Thanks. So we've introduced some concepts, some terms, reference architecture, socio-technical infrastructure, some different ways of thinking about things. Reactions.
So, John, this is Mike. I don't know if you saw Dick's comment that just came on our group chat. But
No.
You might want to read that to the group. This is a really good discussion point that I'm happy to contribute to.
I don't have the ability to see it.
All right, well, let me then read it out. So it seems to me that one of the primary ingredients here for building an infrastructure that works for all is that trust among potential participants, recognizing there are many inherent conflicts of interest and turf conflicts, is an essential piece of the foundation work required. With the trust component work never being a one and done thing, but rather an ongoing nurturing process among the humans who are doing the work. What are some of the lessons learned from our colleagues here that might help us? What a great question.
Who is that?
That's from Dick Thompson from QHN.
So let me at least say a couple things about that. That has been the longest and hardest road we've tried to manage in Jackson. We've had to do a lot of work to build trust just within the medical community itself for reaching out, and that won't come back and bite us in the behind. There are primary care doctors who love the idea of what we're trying to do, bringing community care in, but of course it adds more work. That work is very difficult if there's no infrastructure to support that work. The specialty clinicians and the hospital are also not so sure about the transition. They like to get to the point that we're going to get to the end, but the transition is hard work. The community side, kind of when you get down into the lay community, has heard this before, and so we have to show that we mean it this time, and we do this by convening community sessions, by talking, and by beginning to make some real inroads about coordinating about this and then saying, we've done some progress, let's feed it back to you. So yeah, the trust is hard. And we started in the Jackson community at a place where many communities aren't at by having brought health improvement, community stakeholders, lay community members, and the medical enterprise together already. Yet the trust has still been kind of hard to develop. It's not a one and done. Our goal within the next year is to create a community stewardship group. We currently have the Health Improvement Organizations Coordinating Council, but they are largely composed of stakeholders, not lay community people. So we have to create a stewardship and governance group that is more inclusive. And that's probably one of the main priorities on that big whiteboard behind me, is getting that work done. Because Dick, you're absolutely right. It is an ongoing, nurturing process that has to have some small successes to build that trust over time.
So in the northeast of England, we're very aware of the fact that trust is fundamental. It's not just trust with citizens and clinicians, which to a certain extent was lost during the care.data debacle, but that trammelled through to their clinicians in primary care who've got a lot of data and who want to protect it on their patients' behalf. So we found that going around the region using the technology people to go and have discussions about signing data sharing agreements has not succeeded, but it has succeeded in the north of the region, getting clinicians to do it. So the chief clinical information officers have gone around giving presentations to family doctors in groups, and you reach a tipping point, and then the data sharing agreements all start to get signed. So it goes from 2, 3, 4, 10, 15, 100%, like that. So we've succeeded to get data sharing agreements for frontline care data in the north of the region. That's 1 million people, and we've got 2.6 million in the south, and we're working on that by learning from the experience of the north. So the other people that you have to gain the trust of are the organisational leads for technology, who work for the organisational chief executives, and they don't want to get it wrong. So the infrastructural components which we might want to buy, which we're looking at, are not familiar with many of them. No one ever got fired for buying Cerner. No one ever got fired for buying Epic, or it used to be IBM. And so they are very, very suspicious about this move. And it's just slowly keep meeting with them. So we meet with them every 4 to 6 weeks, and we've given them the power, actually, to build the infrastructure. And you start hearing words like regional hub cropping up on their side of the table, so as if it's their idea, and that's really good. So I think we're getting there, but it's hard work, and it's very dynamic, ongoing process to keep trust going.
If I could say one more thing to this too, Dick, and everybody, it's we began with an outline of a socio-technical design approach to doing this work, and it was very heavily focused on getting engagement and conversations going between the community and the medical enterprise and those of us that were well-meaning helpers to try to catalyze that work. And you can draw up plans to doing this work, building from just understanding of the community, beginning to actively engage the community and seed the discussions about the reference architecture. But it's all looping. It's not linear work. And some of these things move ahead in other ways and others don't. So you can draw plans. And actually the group at UC, Don's group, has thought about this in a lot of depth, trying to figure out how to do this kind of socio-technical, community-engaged implementation work. So there are some guides out there, but you have to be very careful that they match what your community is able to do.
Ready.
So on the topic of trust, I'm just to drill down a little bit furder, trust in one way is a big nebulous thing. Do you have trust in government? Do you have trust in a hub, the organization you're putting together? But you could also drill down to a very granular level, like granular consent, saying, do I trust Don with my clinical record, or do I trust Don with my specific behavioral health record, medications, that sort of thing? And I'm curious if, when you all are referring to trust, whether it's in England or Michigan, are you thinking maybe even down to that granular consent level, or are you thinking about more nebulous or larger scale trust?
Yeah. I think Mike may want to say something about the joint act of publication, a term that was on one of the earlier slides.
Yes, okay. Well, just a minute. There's two things here. First of all, there's a language here. And Nick referred to the experience we had in the Durham and Darlington project, where for the first 2 years of the project, it was an endless argument, mostly among clinical folk, about my stuff and your stuff and access control. Okay, so this is a discussion that's couched almost entirely at the the bottom level, where the data is the stuff. Never mind the meaning, it's here, and it's all about access control. And it was very, very unconstructive. It was at a very particular point where we injected, and it wasn't quite deliberate, the terminology joint act of publication. What do you mean, joint act of publication? What do you mean? What could it mean? Okay. Yet then sorting out, what could this term possibly mean to us? Because, we're going back to 1450. Okay? Gutenberg just started moving the typewriter. He's got his uppercase, he's got his lowercase. And this is the first time when these terms, publisher, editor, author, come into being. Before then, it was church was publisher, God was the author, the monks was the designer, and there's a long history of redefining and renegotiating what it means for all each new technology of communication. So another set of stuff that we do, and there's another set of seminar things that we do, it's about the reintroduction of those models which were the commonplace of mass communication in the publication industry up to the mid-80s, which then got clutched together with everything else. And, we've got to go like that, and that's what you've got to bring back. So there's an issue here, purely about language. So I had a wonderful example, for example, when I had some municipality folk, I had some third sector folk in the room, and we're talking about catalogues of children's services. And I introduced some of this stuff, and the guy turns on his colleague and goes, "You're just treating us as informants. Where's our editorial control?" Imagine, we change the conversation, there's a new possibility. Okay. So there's a pure alignment. So trust here, you're quite right for the rhetoric. We've got to move to a more precise language, and part of the intentional part of that language, the conversational level, is this publication. Okay? Now, the second thing we've got to say, I think, is that I have technical colleagues I've worked with for years and years and years. They are very, very smart guys. And they have made several tools for fine-grained policy delivery. And they've got wonderful technology where you can take a piece of data and put it in a package, written on the package a set of policies. If you accept those policies, you get access. And this is actually a legal instrument. Okay? And wonderful, a very subtle thing like that. You can package up a database with different fields, with different packages and all sorts of things. They're incredibly fine, detailed stuff. And they're really frustrated because nobody can articulate the policy that says, multiply this. Well, you're not using half of it, you could do this. Okay? They simply haven't got the language. Now, we've not done this yet, but I'm pretty confident that we could make a tool that could take the outward ending page discussion and provide scripts to program that sort of technology. Okay? I'm pretty sure we could do it. How do we convince people that their intentions are being acted out? This is the big challenge. You see, the potential's there, but the issue here is the commitment to the conversations, the commitment to having them, and for them being like real conversations. Because it's only through that, because trust really exists at the top level. It's a socio-cultural thing. It's real life. So I'm laying out the stall. It's not answering the question. These questions are only answered in reality on the ground.
Yeah.
So we do envisage allowing patients to take control of what data is shared for research purposes. And I think when that starts to happen, people will get nervous about it. But there are circumstances...
I just think that's a key point, and that is that maybe when individual people or patients get control, maybe they'll understand better what we're talking about and the distribution of their own information, and who gives permission to see it.
Yeah. So if we could get an elected council that could basically vote on what were worthy sources of research and recommend those to patients, I think that would be a start. Patients might sort of say, well, I don't like this embryology stuff, that's against my religious belief, and opt specifically out of that one. But we also have to bear in mind that there are quite a lot of legal instruments which allow people to do research on anonymised and pseudonymized data. And there's that tightrope to walk between assembled large data sets and somebody having enough information about an individual to basically be a key to a pseudonymized or anonymized data set. So we're not just talking about clear-cut stuff, we're talking about assessing risk, and it becomes very difficult. But I think getting the patient basically to feel that we're a trustworthy organisation, that the Great North Care Record is a trusted brand, and that we're not going to do anything wanton with their data, will be a great start. So that's our dream, really.
Yeah. This is Mike. If I can say just one thing, one maybe specific example about this idea of a joint exit publication. We anticipate that by focusing on the care record and the value of communicating about care events and what's happening for a person between domains, people will understand that has value. And then we would like to extend that to the idea of Mrs. Jones or someone in the community completing through a portal their outcome measure on some regular basis to see whether they are doing better in the ways that we hope they might do better. For example, we have done this with an application following people with behavioral health problems so that they can report their PHQ-9 score over time. And the joint act here is that the person who is in the community receiving care agrees that they will put their PHQ-9 data into our system with the expectation that someone will act on it if it shows something that is troubling or worrisome. And we've had many examples over the years in the work in Ann Arbor that people do that and they get reacted to and responded to because there is an agreement, an implicit agreement that I'm putting this here so that you can act on it. I'm putting it out there because I believe that you will help me based upon what I'm doing. So in the community, we want to have those discussions, not just about a specific outcome metric like a PHQ-9, but just the things that we believe are important for Mr. Jones or Mrs. Jones or the other examples we can come up with over time so that they publish the report with the expectation that it is part of a stream of care that is valuable to share among the carers in the community, not just to go into a database inside an electronic health record somewhere. So I think the argument, if you want to use the word use case here, the use case that opens this discussion up is we are working to help provide better care for you by doing these joint acts of publications about things that we think are really important to doing that.
I'm looking to see if there's other people that need this. So, gentlemen, what should happen next?
Good question. I think, from my perspective, part of what we're trying to do here is get some common language out on the table. And I think this concept, I think this concept of a reference architecture is extremely useful, sort of having a vision for how an infrastructure could work. And then it's beginning to have the conversations of, okay, what do we want? What sorts of things do we want to enable with that reference architecture? That's just my first take. Nick?
Well, we started out showing the architecture to some senior people in the NHS 2 or 3 years ago, didn't we, Mike? And 2 years ago, and we began 2.5 years ago, we began to think that what we'd like to do is create a movement, and we didn't really know what we meant by that. But there are people who are allies of, who are fans of this architecture in the northwest coast area of our connected health cities, as well as the northeast. And we've now got the Quality Health Network in western slopes of Colorado, what we saw in Durango, and in Michigan and in Colorado. So maybe we should try and recruit some more people to our movement and build on the reference architecture and the discourse and start to widen the appeal.
And just picking up on that, in the UK at the moment, there is what I've called a coalition of the wise and the willing on the supply side forming. So there's a really interesting issue here, which is who can supply federation services and on what basis, and who's the customer? Now, a federation service is a shared third-party resource within a community. So the community have to procure it as a community, so they need to create some vehicle through which they can procure it. Okay? But there has to be a supplier. Who's the supplier for this? Now, I'll give you an example here of the sort of thinking. So, talking to some of the basic communications suppliers, the dark fibre suppliers, and they want to grow their business, particularly the ones supplying the public sector, they want to grow their business. So what do? Well, we have the wonderful example of British Telecom, who operate the core business was at that level in the UK, who moved up the value chain, became systems integrators, supplying middleware services, and basically competed with and outdid all of their customers and made everybody unhappy. Okay? And it's not been a very successful thing. Okay? So what's the alternative? Well, the classic way that an infrastructure supplier grows their business is by nurturing their customers. Okay? Because if you nurture your customers, that generates traffic, and traffic is your business. So one of the things that's happening at the moment is talking to some of these people at the bottom of the infrastructure ladder, saying, look guys, you need to move up the value chain and offer some of these services and coordinate the offer of some of these services, but not on the basis of extracting revenues and rents, but on the basis of this is a market due. And what you're doing is enabling your market. So you offer it on a basis that, this comes back. This is federation as a service, guys. It's on the okay? Now, I'm involved at the moment in some discussions with some pretty hair-raising people in the industry. And the name of the discussion is 5G fabric. Now what they mean is, how can we make our cities a fit environment for self-driving cars? Okay, that's what they think they mean. Okay, but if you look at what's demanded here, it's what we've been talking about. It's this idea that, yes, you might log on as a customer and as a subscriber, but actually it's your centrality that is the issue. And that's where the value at. Okay, now, if that's just done on the basis of Google and Apple, it's the walled garden, and you're selling your soul to them, and they're going to commoditize your relationships and everything you do in order to make money. You're back where you started. I love it. We know we're worse than where we started. We're a lot worse than where we started. Okay? But the idea that, and I'm not saying they shouldn't do it. No, don't get me wrong. I'm not saying they shouldn't do it. It should be there.
Right.
And we should know it's there, and we should understand the relationships.
Right.
But also, we need to be able to create these spaces where our care communities can deliver care in an appropriately governed way and exploit these technical capabilities in the interests of the community. Okay? The technology is the technology is the technology. It's the intentions that are different. Heard that before?
Right. It's the trust that's different.
Exactly. So we've got to somehow make it... Okay, so the point here is that there's stuff going on at the moment. This is happening. We're not saying anything that is technologically new or challenging here. That's not where the innovation is.
Right. It's the relationships that are challenging.
It's the innovation of the relationships, precisely. Okay.
I'm just curious. I want to get to Scott's comment or question. Curious just to see a show of hands. How many people here would identify themselves with the provider or clinician community? How many people with community service organizations? Okay, great. Payer community? Okay, great.
Got the representation.
Yeah.
It's you guys, you've got to negotiate your reference up.
Scott.
Great comprehensive view of sort of great roadmap to health. I would, and correct me if I'm wrong, however, my understanding of the British system is that it's based on primary care. And the structure that you outlined is going to be more conducive in a primary care supported system. Now, in the U.S., primary care is, we live in a specialized, fragmented, very siloed, anti-primary care world. So I think we have real challenges to try to develop a roadmap that you outline, because there is no stakeholders, there's no health plans, there's no government policymakers here, no one who controls the finances. Back there?
Policy.
Right. Okay, a few. All right, but this is driven by money. So to Lauren's comment, what are the next steps? I would say, well, we first have to become interested and supportive of primary care in this country. We have models, the patient-centered medical home, sort of stagnating right now. It needs to evolve, and why I'm here, to the community-centered medical home, to become a comprehensive care plan. And yes, everyone has sort of talked a little bit about establishing common ground and common language, and maybe a grassroots effort to, develop the information that needs to be sent around to really kind of push this. So, just as a plug before I end, that's just a comment. That wasn't really a question, but our clinic, I'm just a pragmatic primary care private practice doc. We've developed a medical neighborhood compact and agreements. We've developed a shared care plan. Really working on the standardizing and informatics, and hoping that is the common ground and the common language to connect clinicians to start this grassroots effort. So anybody in this room who is really interested in promoting that, connecting, developing that primary care hub to connect the medical services and the behavioral health and the community services, come talk to me after this conference.
I don't disagree with whatever you say about the United States. I'm not in a position to, but there's no way that primary care is in charge of what's going on in the NHS. That's a fallacy. I mean, you know, the big power bases of money and finance are still the hospital sector. I mean, there is general support from the administration, from the government, from, you know, the people who make policy of getting this sorted out. But they have no view whatsoever on how we sort this problem out. And people continue to believe that the only way to solve the problem is by making bigger organisational integrations. And we know that all that will do is make more and more and more islands of data which need to be bridged. And what we're offering is a way of bridging the islands of data. It may actually be cheaper, and if people actually see that this is being implemented bit by bit, they will gain confidence in this technology, realise it will save them money, and it will happen. I believe that to be the case. So I think that could happen here just as well as it could happen over there.
So you're absolutely right. Technology is not the solution to healthcare problems. It's healthcare is relational. And how do you transfer information into data that is relational to help clinicians and the people who provide services to individuals do their work? And, you know, that's what we're trying to do.
Bingo. Just a comment.
If I can say something from the back seats here. Now I don't get any time to talk about this, because what we've seen in Michigan is that as this has started to evolve and as Jackson became part of what became the SIM demonstration in Michigan, I see these two solutions as evolving in parallel. The information infrastructure that you need to make this work, and a clear redesign of how the medical side delivers care to make the patient-centered medical homes more capable of carrying out those neighborhood and integrated responsibilities. Because I agree with you completely. This is personal care over time, so it has to be context-driven and has to be relational and longitudinal. And then there's a sort of a population management superstructure that is some of that stuff that I showed in that triangle slide about the intelligence and the reporting that isn't necessarily relational, but you want to do co-design, and that co-design process we had hoped we could roll into our SIM demonstration. That remains to be seen, but that's the highly ambitious aim that we took on in Jackson, trying to get these issues on the table for SIM.
I'm forced to respond that because okay. So yeah, you know, this idea that my sector, my industry, has screwed it up and screwed you guys so long that, you know, we've got this thing, we're the technology stuff and we do the relational stuff, and the technology stuff is over there, we do the relational stuff, and, you know, blah, 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 and not really talk to each other. So what I've been struggling to do, and it really is a struggle, is to say there's some stuff where we've got to be systematic, and, you know, in your clinical world, there's places where the clinical science, if you're not going to be serious, then you're seriously wrong. Okay, but then there's also the relational stuff. Okay, so the effort that I've been trying to do here is to try and create a language, or the possibility of a language, where there can be a conversation. And there are many of these conversations, and the conversations have to be a conversation of mutual sense-making. Okay? At this level that we're talking about, we have to be seriously trying to understand. Okay? So what I've been giving you this morning has been the result of 35 years of struggling with, on the one hand, trying to get the technology under control, but having achieved a little bit there, having realised that when the technology is deployed in these contexts, with this level of complexity, the moral dimension, the ethical dimension,
the historical dimension.
Okay, where do you draw the line?
Correct.
And what do you do below the line, and what do you do above the line?
Exactly.
Now this then comes to what is the core of infrastructure. And infrastructure is a line on the world. Okay? We do stuff below this line to engineer and systematize things in order to make some things possible above the line. Not to engineer and systematize them, to make them possible. Okay? You're not engineering them. Okay? An application, you're trying to engineer it. With infrastructure, you're trying to engineer something down here that makes it possible. Now, you're making things possible. Who are the most creative guys in the world? The bad guys. They're the big innovators. Okay?
Okay.
You look at history.
All right, fine. Okay,
So, if you're building infrastructure, and while it's making wonderful things possible, it's also making bad things possible.
Correct.
You've got another responsibility, which is how do you inform above the line about what's going on in order that they can make the decision, we like that, we'll carry on with that, we don't like that, we want that to change. That's governance. Okay?
Yep.
So the issue we've got here is this is a new sort of conversation between the technicals. This is what I started out with, the architechne. We're saying a new sort of conversation. So in these conversations, first of all, we put our technes aside and we have a talk about what counts here. Okay? What's significant here? And that's an argument. We then, as a result of those conversations, go away and do technical work. And then we come back and say, do you realise that if that's what this and this and that, maybe we ought to, maybe we're not. Okay? But there's these two jobs. There's the signification, that's right, what counts, and that's something we all have to do together, irrespective of our techniques. Right. Then we've got to do our technical work and take the consequences back into that conversation to
rebuild the infrastructure.
Okay? Right. And you're doing this, you might be doing this in the framing of we're going to build a system, or we're trying to keep the system under control, it's the system in use. There's never a greenfield site, it's always a brownfield site. Right. But you see what I'm saying? It's the conversation that's the issue. And it's heartbreaking when you see the damage that has been done by... I mean, if you guys think you've got it bad, look at social care. So, information systems in social care have been nothing but control and abuse, certainly in the UK. They've been nothing to do with supporting the delivery of care. They've been to do with getting stars for the director. It's horrific. And now we're in this situation where we're trying to integrate health and social care, and you've got all this scar tissue and all this damage.
And don't talk about behavioural care.
Yeah.
Right.
Behavioural health issues.
Exactly. Now, but then the final remark on the remark that you made there about it being primary care. Okay. I'm having exactly the same discussions at the architectural infrastructure level with people who are doing economic development and business support. Being a small and medium enterprise in today's economy is a complex long-term condition. Mm-hmm. It requires something from there, something from there, something from there. Oh, shit, those don't fit together, that's not a bit... You need to be learning. This idea that you've got a hub, you've got a whole bunch of different components of solutions, and you've got complex combinations of problems, and you've got to respond, and you've got to learn. So, this isn't a health infrastructure, a health architecture. This is an architecture for, getting things done. Yes, yeah.
So one question I'll throw out, I'm going to put you on the spot, Lauren, and you can say we could talk later. But I'm curious if continuing this conversation would fit into any of the working group models that the Prevention Alliance has been convening.
I would put that, does this work? I would probably put that to those of you in the room. I think there's certainly room to think about how some of the work that we've all been talking about doing, connecting folks around social determinants of health and community and medical care, also or is in alignment with this. But I'm really interested in those of you in the room who have been having these conversations from multiple different organizational perspectives. Think about that, and it's probably part of why some folks are here. So I think it'd be great to open that up for discussion for folks here. How to continue the conversation, and or if it fits into something that you think you're working on or we should be working on further.
I mean, I think it absolutely fits into the conversations that we've been having around putting together the data resources with 211 and trying to figure out how do we develop a hub, as Art Davidson calls it, which is just a resource hub. How do you connect the pieces together? And different people have come up with different conceptions of that. If you look at TAV Health is really designed to be more of a communications hub. If you look really hard at what the folks that we thought were too expensive, Health Leads does, they design theirs more around sort of the resource exchange. If you look at what the version of this stuff, this hub that we've been looking at, which is we're calling it Colorado Source, but comes from California, really is more about relationship, is more about community. All I'm saying is that each one of these different folks have come up with essentially the same idea, but because they're approaching it from different directions, the infrastructure, that architecture looks different. It has a different dynamic to it. It has a different purpose in many ways. And so that's just one conversation, if you will, about one type of hub. To your point, we're talking about social determinants of health when we were having this conversation. And yet there are all of these other things in play at the same time. Out of all this conversation comes this concept of complexity and flexibility and the relationship between the two of those things. How do you develop something that addresses everybody's issues, that really has this federation, as you called it, in mind with different hubs, and still have it be something that people can use, something that's not so complex that it doesn't get too far away from life, real life, that people don't access it. They don't go for it. I think all of the conversation that we've had, all of the diagrams, all of the pictures, I love the fact that it's happening in Michigan and that it's happening in the UK, that it's happening here in Colorado, it's happening in California, it's happening in all the places that we've had conversations with. Baltimore, New York, you name it. It's wonderful that it's happening. The question just becomes one of, how do you connect these conversations together so that you really do develop what you just asked for, which is some version of something that everybody agrees enough to. Now, realistically, because I'm going to have to go realistic on you, because this is all great. This has been an absolutely wonderful conversation at a level that is somewhere up here, right? Realistically, the divides that we have just seen play themselves out here in the United States and in Britain, yes, do not lend themselves to what we've been talking about. So realistically, until we get to the point where we can have the social conversations that get past some of those divides, your architecture is dead in the water. Yes?
What you're saying rings very, very true. Mm-hmm. Okay? And I'll be very, very frank with you. Mm-hmm. The strategy we have is basically based on Trojan horses.
Correct.
We can't explain this to the funders. We can't explain it. Okay. Okay. Even in our own region in the northeast, they're frightened to death of this. Okay. So they've got doing. Okay. And we're having to infiltrate it by stealth. But this is the issue. This is why we've introduced this concept of the reference architecture. Okay. And it's this concept that Nick was talking about leadership. And it's not leadership of the one, it's community leadership. I came into health and social care at the turn of the millennium. I have watched, I think it's now in the UK, 4.5 generations of major investment in the public sector.
We call it the war on poverty here.
It's the public sector, okay? So the public sector is driven by policy. So we're going to make an investment. What's the investment for? To implement the policy. We build structural systems that have the policy inscribed in them. By the time we've finished them, the politicians have gone and the policy has changed. Throw it away, do it again. 4.5 times you've seen that now. And it's going around. And there's almost nothing left. Go back to the details of this 13 billion that Nick was talking about.
Right.
Okay? So they installed this stuff and he gave his success list. Then the money ran out. Oh, we're switching it all off.
Or the politics changed.
Now, yes. Now, as Nick did say correctly, there was some infrastructural stuff about the spine. I mean, I hate the name. How many spines have you got? Mm-hmm. Just the one. They're telling us something, okay? The spine actually was a political device where we've got this technical artifact here, and if you put things on it, it's controlled from the centre. So it's a tool for policy and control, okay? But leaving that aside, they spent a lot of money on this thing, they switched it off, and it was re-implemented using open source at a tenth of the cost. Okay? So there's various things going on here. The first point is that having a reference architecture is what we're trying to do is give you a tool that means that you can squirrel away stuff from successive initiatives that are going to come and go that might have a life beyond the initiative. Because your experience has all been second and third generation stuff is always better than first generation stuff. So can we preserve something
through the
from the past? Okay? Mm-hmm. You can't say, this isn't a seller. I'm not offering you a way of selling to gain funds.
Right.
It's nothing to do with that. You've got to play the game to get the funds. It's the same. You're going to do what they say you're going to do.
Right.
And then you've got to do it and satisfies it. But if you have this concept of a reference architecture, the sort of thing that can happen is, oh, by the way, do you realise it does this as well? Oh shit, that's good.
Nice.
And do you realise that if you made another of these and put it over there, we could connect them together and it does it? Oh shit, that's good. Okay? And these are all icing on the cake as far as they're concerned.
Right.
But otherwise, you're stuck in Groundhog Day.
Mm-hmm. Yeah. A couple more weeks of winter.
Yeah.
So I think this is the result of 25, 30 years of applying the principle, how can we improve the quality of the mistake we're making? It's always going to be a mistake, but how can we make it a better one?
And I would gently push back, Arthur, on calling Health Leads a hub. It's an application. It's built to serve a specific use case.
Sure.
That's not what we're talking about. Now, what we're talking about could be greatly enhanced by...
And the point I'm making is, you might build something to deliver a particular application.
Right.
But you've done it in a way that it can be infrastructuralized.
Right.
Yeah.
Okay. I agree with you, Don. I think Health Leads is an application. But if you multiply it across enough places, you can get to the point where it becomes infrastructure.
For that use case.
Yes.
That it's built for.
Yes.
So I want to be respectful of folks' time. We're getting up to the noon hour. This has been
strong, 3 hours. Strong.
Yeah, this has been great. I think for just about everybody, we have your contact information. If we don't, please make sure that we have that written down. Linda Niebauer at the back of the room, I think we have sign-ups, but I think we've got everybody captured. We'll try and send out something to both get your feedback on what we've done this morning and perhaps dig into a little bit more of this question about what next. And
I have to say, Don, you've been very patient.
That's right. So thanks very much, and thanks to Mike.
Mike and Nick and Don, thank you very much.